I'm Dr. Paula Gordon. I'm a breast radiologist and clinical professor at the University of British Columbia. I volunteer as the medical advisor for Dense Breast Canada. I'll just call that DBC for short. DBC has been advocating province by province for better breast screening practices since 2016. And I'd like to thank MLA Jody Byram for the opportunity to speak to you today. So in the next 15 minutes, I'll provide information on two critical issues that are currently impacting early detection of breast cancer in Manitoba. First, women aged 40 to 49 in Manitoba cannot self-refer for a screening mammogram. And second, women with dense breasts cannot access additional breast cancer screening. Breast cancer is the most common cancer in women in Manitoba, accounting for a quarter of cancer diagnoses. In 2023, approximately 900 women in Manitoba were diagnosed with breast cancer and 180 women died of it. Behind each of these numbers is a woman and her family. We know some of these deaths were avoidable, and we can do better for women in Manitoba with improved breast screening practices. Let's first take a look at the need to start breast screening at age 40 and allow women to self-refer for mammograms. This data from the US shows the distribution of breast cancer cases by age at diagnosis. The incidence of breast cancer increases significantly at age 40. 17% of all breast cancer cases occur in women in their 40s, 25% in the 50s, 26% in the 60s, and 17% in the 70s. Now, these data are from 2015, but there's new evidence that the incidence of breast cancer is increasing in young women. There's a misconception among the public and healthcare providers that women don't need screening till age 50. But you heard 17% of breast cancers occur in women in that age group, 40 to 49. 24% of years of life lost and 14% of deaths from breast cancer occur in women diagnosed in their 40s. That's because although breast cancer is less common in younger women, it grows and spreads faster. So it's potentially more lethal. Moreover, breast cancer is the leading cause of death in Canada from women aged 40 to 55. Canadian research shows that women in their 40s who have mammograms are 44% less likely to die from breast cancer than those who don't. There's also a misconception about who's at risk for breast cancer and who needs to be screened. It's surprising to many women and even physicians that 80 to 85% of women who get breast cancer have no family history. So all women need to be screened. Now, mammograms can find cancers on average 2 to 3 years before they grow large enough to feel. Early diagnosis is important because it impacts survival. When cancers are found small at stage 1, virtually all women are alive 5 years later, but survival diminishes as the stage of diagnosis goes up. 5-year survival for women diagnosed at stage 4 is only 22%. In addition to reducing deaths, early detection improves quality of life for women with cancer. When cancer is found early, women can have the choice to have less extensive breast surgery, like a lumpectomy instead of mastectomy, and they may be able to avoid chemotherapy, so they have less psychological and financial impacts. Women can also avoid the armpit surgery for lymph node staging, which often leads to lifelong pain and swelling caused by lymphedema. Minority women, including Indigenous, Black, Asian, and Hispanic women, get breast cancer younger than Caucasian women. Black and Indigenous women are more likely to get more aggressive cancers, be diagnosed at an advanced stage, which reduces quality of life and increases the risk of dying. Research by the University of Ottawa and Statistics Canada showed that provinces that don't screen women in their 40s have higher rates of advanced breast cancers in women not only in their 40s, but also in their 50s, and that translates to worse outcomes. Last May, the US task force announced that it was going to lower the recommended screening age from 50 to 40. Now, that decision was based on racial disparities and the rising incidence of breast cancer in younger women. The Canadian task force is reviewing our breast screening recommendations, and they're expected to be published shortly. Currently in Canada, look at this map, 4 jurisdictions screen starting at 40, and they've done so for decades. In October, Ontario announced that it would allow self-referral starting at 40, beginning this fall. New Brunswick also announced it would start this year. Saskatchewan just announced it will start in January 2025. 10 days ago, Northwest Territories lowered the screening age to 45. These jurisdictions made these commitments even though the Canadian Task Force review is still underway. Quebec is doing a review expected in the fall. It's reassuring that all these other provinces have chosen to follow the science. They will reduce avoidable deaths and suffering and even save money. There are so many demands on the healthcare system besides breast cancer screening and treatment, but finding cancer early saves healthcare dollars. With new treatments and higher survival rates, the costs of treating women with later stage breast cancer have risen significantly. Last year, Canadian researchers found that treating stage 4 breast cancer can cost over $500,000 per patient, depending on the subtype. A screening mammogram costs as little as $65. The same researchers who looked at treatment costs have found that breast cancer screening for women in their 40s is not just cost effective, it results in cost savings of approximately $200 million every year in Canada. Women aged 40 to 49 cannot have a screening mammogram in Manitoba unless they have a referral from their doctor, and most don't even know to ask. Moreover, a growing number of women don't even have a family doctor to provide a requisition, which makes it more important that women should be able to self-refer. Many physicians are reluctant or refuse to give a requisition, stating that they're following recommendations from the Canadian Task Force. When women do get a referral in their 40s, their mammograms done outside the screening program, and that's less than ideal because their outcomes may not be audited or included in provincial statistics. So to sum up this issue, screening starting at 40 saves the most lives from breast cancer, and early detection gives better quality of life. So our recommendations are that all women aged 40 to 49 who wish to have screening mammograms should be permitted to self-refer annually to the Manitoba screening program. And it's especially important for racialized women, including Indigenous, Black, Asian, and Hispanic women who tend to get breast cancer younger than white women and who have poorer breast cancer outcomes. The other issue is supplemental screening for women with dense breasts. Thanks to DBC's patient advocates, in 2021, Manitoba began to directly inform women of their breast density category, A, B, C, or D, after their screening mammogram. So women can learn if they have dense breasts. But in Manitoba, they have difficulty accessing the essential additional screening they need to find breast cancer early. Mammograms do not find all cancers, and having dense tissue is the most common reason for a cancer to be missed. Dense breasts are normal and common. 43% of women over age 40 have dense breasts, and dense breasts are more common in Asian and Black women. These breasts from 4 different women look quite different, but they're all normal. The dark areas are fat. The white areas are breast tissue. Now, dense breasts have more white tissue than fat. Radiologists divide density into 4 categories. Categories A and B are A is almost all fat with increasing levels of density, and category D is almost all white. Now, cancers are also white, and this video shows how even a small cancer that's easily visible in non-dense breasts is difficult or impossible to detect in category C and D. As many as 50% of cancers are missed in category D breasts. So there are 2 risks of dense breasts. As you've just seen, dense breast tissue increases the risk of cancer being missed on a mammogram. But in addition, dense breast tissue also increases the risk of getting breast cancer. Women in category D have 4 to 6 times higher risk of breast cancer than women in category A. Women with dense breasts are not at average risk. Women with category C have 1.5 times higher risk than average to get breast cancer, and women in category D are at twice the risk. So this chart shows that categories C and D have higher risks than women with a mother or sister with breast cancer. But among women who do get breast cancer, having dense breasts is the most prevalent. Category C breasts are present in women with cancer more often than those with a breast cancer gene or a mother or sister with breast cancer. So cancers that are not found because they're missed on the mammogram and they're not treated continue to grow until they're large enough to be felt. And we call them interval cancers because they're detected in the interval between planned mammograms. They're larger and more likely to have spread than cancers detected as screening, and they tend to be more aggressive. Those women are more likely to need mastectomies and chemotherapy, and they're more likely to die of breast cancer. Women with dense breasts are at a higher risk of an interval cancer, so they need more than mammograms to prevent their cancers from becoming interval cancers. Women in Manitoba with dense breasts are discriminated against if they're not given access to the additional screening that will reduce interval cancers. Now, we've known about the risk of breast density for about 50 years, and we've known for almost 30 years that ultrasound can find additional breast cancers missed on mammograms in women with dense breasts. We can find them when they're small and prevent them from becoming interval cancers with supplemental screening, usually with ultrasound, but sometimes MRI. MRI finds the most additional cancers, up to 16 cancers per 1,000 scans missed on mammograms. So today I'm focusing on ultrasound for women with dense breasts, as it is more accessible and is available in other provinces. MRI is used in some provinces for women with a calculated lifetime risk over 25%. So we know that there are barriers to accessing supplemental screening. First, there's a shortage of ultrasound technologists. We need to incentivize young people to enroll in ultrasound training programs, and then the compensation for the technologists has to be competitive so they stay. Second, another excuse to withhold ultrasound is the false alarms. Now, like mammograms, ultrasounds find abnormalities that ultimately prove to be benign. And the need for additional testing does cause anxiety for women, but it's transient. And that anxiety is nothing like the anxiety of learning that you have an advanced breast cancer that could have been detected sooner. Short-lived anxiety is not a reason to deny women the opportunity for early detection. Women in Manitoba should be informed of the possibility of false alarms, but they can make up their own minds about which anxiety they'd like to risk. It's paternalistic for that decision to be made for them. A third barrier is the excuse that there isn't enough evidence yet to show that supplemental screening with ultrasound reduces deaths. But we have that evidence. A randomized controlled trial would be needed to prove that it reduces deaths, and there's one underway now in Japan. They've shown a 50% reduction in interval cancers. And since we know that reduced interval cancers precede mortality reduction, we don't need to wait for the study to finish. We can start now to prevent countless women from suffering and dying from advanced cancers. Screening ultrasound for women with dense breasts, category C and D, is accessible in British Columbia. The clinic where I work performs about 4,000 screening ultrasounds a year, finding 7 additional cancers per 1,000 exams that were missed on their mammograms. Bear in mind that with mammography, we find about 5 cancers per 1,000. And here with ultrasound, we're finding an additional 7. Ultrasound is also accessible for category C and D in Alberta and Ontario, and it's covered by provincial health insurance. Guidelines for supplemental screening for women in category D have recently been announced in Alberta and Northwest Territories. Ontario published a recommendation for screening category D. PEI has committed to ultrasound for women with category D. In other provinces, access can vary, but it's not easily accessible in Manitoba. 7 provinces offer annual mammography screening to women in category D. Manitoba does not. Based on randomized trial data from the Netherlands, the European Society of Breast Imaging now recommends MRI every 2 to 3 years for all women in category D, but no less often than every 4 years. Yet in Manitoba, screening ultrasound is not even easily accessible for women with dense breasts. Now, I've included this chart you can have a look at later to compare the provinces. But I caution you to remember, women in category C account for the greatest number of missed cancers, so please don't ignore them. Here's what's happening across Canada. DBC prepared an overview on 5 optimal breast screening practices. These include self-referral, starting at 40 and after age 74, annual mammograms for women in the 40s and for women with category D density, and breast density notification for all women. Yukon and Nova Scotia scored 5 out of 5. Other provinces scored 3 or 4 out of 5. Manitoba and 2 other provinces scored only 2 out of 5. You can see that in Manitoba, women with dense breasts and women in their 40s are at a disadvantage in finding breast cancer early compared to women in other provinces. So to improve early detection of breast cancer, reduce deaths, reduce suffering related to breast cancer for women and those who care about them, and to save on treatment costs, women should be able to self-refer for screening starting at age 40 and supplemental screening should be provided to women with category C and a D dense breasts. I'd be happy to answer your questions, but first I'd like to introduce you to patient advocates, Jenny Borgfjord and Shannon Coates, who can speak firsthand to the need for screening in the 40s and the need for supplemental screening. Shannon.
Good morning, everyone. Thank you so much for allowing me to share my breast cancer story. My name is Shannon Coates. So imagine being denied a $100 mammogram when you know your family has extensive history with breast cancer. So you may think I'm just another breast cancer patient, but I'm actually a mother of 2 small boys. Jagger Cruz was 4 years old and Lincoln Harlow was 11 years old when I was diagnosed. These 2 boys lost their own mother's quality of life for 15 months as I watched on the sidelines to participate, and I wasn't able to participate in their milestones. I turned 42 years old mid-June 2022. And 1 month later, I started to notice my right nipple become inverted. I was training for my 8th Manitoba marathon and just thought it was from my sports bra, but I hadn't felt a lump yet through my monthly self-breast exam, but I knew something was off in my breast. I decided to reach out to my doctor in August of 2022, and he took my concerns seriously. On August 10th, 2022, I went for my first mammogram in my life at age 42. I'd never had one because I'd always been denied. When I lived in Montreal from age 25 to 35, I was also denied mammograms. Now that I reside in Winnipeg, I was again refused mammograms from age 40 to 42. My family history has extensive breast cancer in it. My mom was diagnosed with HER2 positive at age 52. My aunt had breast cancer, and my grandmother's sister all had breast cancer, yet a mammogram only costs $100. On August 10th, 2022, at 5:11 p.m., I received that dreaded call from my doctor that confirmed it was breast cancer. And the fact that I had been denied all these years of breast cancer. On August 22nd, 2022, I had a biopsy on my right breast confirming that I had HER2 positive triple negative stage 3, the most aggressive form of breast cancer you can have, costing a minimum of $110,798,000. I began my chemotherapy in August 3rd, 2022. Ironically, it's Breast Cancer Awareness Month. And I had an instant allergic reaction to Herceptin, one of the drugs that I get. Chemotherapy side effects paralyzed my body for 14 days straight each round and were so harsh that I lost my ability to walk, eat food, and I was a shell of myself. I endured chemotherapy every 3 weeks for 16 rounds. Halfway through my treatment, the pain from my neuropathy, bone aches, quality of life had become so bad that I considered stopping chemotherapy. But I decided to go on a drug called methadone. And currently, I am still on methadone because of the ongoing side effects. The port that was put into my chest for chemotherapy within 3 months became infected, and I required emergency surgery in January 2023. Yet again, another traumatic event I had to endure on my cancer journey. February 13th, 2023, I had a double mastectomy with DIEP flap reconstruction to remove the tumor, only to find out that the tumor had spread to my lymph nodes in my right armpit. I ended up having 3 drainage tubes and 15 staples in my armpit. Now I wear this compression sleeve and a compression bra to prevent getting lymphedema. I endured those 16 rounds of radiation in April to May of 2023. The side effects burned my right breast and my armpit so bad that my right breast has shrunk 3 breast cup sizes. On November 3rd of 2023, I rang the bell for the very last round of chemotherapy, but my fight has been far from over. When my pathology report came back, my double mastectomy had mutated to HER2 positive, triple positive, And now I take a daily medication, daily, called tamoxifen, that has pushed me into early menopause. And I will be needing a full hysterectomy. Over the course of these horrific cancer treatments, I gained 38 pounds, lost my hair, amputated both my breasts, had suicidal thoughts, and have ongoing neuropathy in my hands and feet. I have brain fog, memory loss from the chemotherapy, hot flashes, extreme fatigue, bone ache so badly that I, at 43, can barely go downstairs. I was a marathon runner, and now I can barely go downstairs. It's humbling and humiliating. I actually have my next surgery this Thursday. So in a couple days, I will be going to fix and have adjustments done to what I've had already. My breast cancer could have been found at age 40, 41, or 42, but no one would allow me a $100 mammogram in Manitoba. It infuriates me that I've lost 15 months of my children's lives. My 4-year-old son, Jagger, wouldn't let me put him to bed each night or even hug him for 15 months. Why, you may ask? Because my son thought he could catch my breast cancer. Breast cancer doesn't discriminate, so early detection, like early mammograms being offered at age 40, can help find breast cancer at an earlier stage, most likely to be treated, and can be successful. A diagnostic mammogram costs around $100. A test that can save lives, reduce the intensity of treatment in women in the prime of their lives, like myself. But this was never an option with the current health guidelines. It's time for Manitoba to wake up, change the guidelines to age 40 so for early detection, so we can prevent our mothers, daughters, sisters, aunts, and grandmothers a brighter future. Thank you so much for allowing me to share my breast cancer story with all of you.
Last April, I had zero concerns about getting breast cancer because of conversations with my primary care physician and general naivety. Turns out my doctor has received outdated information from their trusted source, and I should have been paying attention. I have dense breasts. In March 2023, I had my second screening mammogram ever, and the results were normal again. 1 month later, I found a lump. Not overly concerned though, I gave myself a week to see if the lump disappeared. My husband had reminded me that I had several days of tenderness following the mammogram, so we thought it could be injured tissues. I guess I was in denial. I just had a normal mammogram, right? The lump did not disappear, so I dragged myself to the clinic on May 4th, fully expecting to be dismissed by the doctor because I just had a normal mammogram, the current gold standard for screening. I was not dismissed this time. After a breast exam and an unsuccessful needle aspiration, an ultrasound was booked. On May 9th, I began to worry as the ultrasound technician became less chatty and more focused on the screen. Following the ultrasound, the technician left to consult her imaging and returned with a radiologist. Now I was terrified. Both staff were comforting, explaining that they found something warranting investigation and suggested an immediate biopsy. I agreed. What else was I going to say or do? And I left that day with a throbbing, bruised breast, dreading what was coming my way. After a very long 10 days, my doctor phoned and I officially became a cancer patient. 5 days after diagnosis, I visited the local breast surgeon. Relief flooded over me as she explained the biopsy results, among other breast cancer things, and a lumpectomy date was set for June 13th. Then, because the lump was not detected on the mammogram, I was sent for a breast MRI. So that relief that I felt, it was short-lived because another mass was revealed, also not picked up on the mammograms. This finding delayed surgery as I sorted out what to do. In a very short time frame, less than 24 hours before the surgery, I had 20 minutes to decide if I wanted a mastectomy the next day or delay surgery and get another biopsy. With much trepidation, I opted for the biopsy, and so began another long wait for an appointment and results. Every second that ticked, I second-guessed my decision. Thankfully, 16 long days later, the second mass was identified as non-cancerous. Would have been nice to know that beforehand, though. My lumpectomy and node biopsy were completed on July 6th. Then, 10 long weeks later, my treatment plan was developed and executed once my cancer care referral was accepted, appointments were attended, and further testing was completed. I am one of the lucky ones so far, as my diagnosis is early stage. I shudder to think where I would be a year from now, in between mammos, and if I believed that breast self-exams were not helpful. Throughout this journey, I have reflected and researched extensively, ensuring I understood what was happening to me, and this led me to find Dense Breast Canada. I have spent many hours with Dr. Google, but don't worry, I only use reputable sites. One of the pivotal pieces of information for me was learning about the complexities of dense breasts that Dr. Gordon discussed. When I began publicly sharing my story, I was alarmed that people around me did not know either. Supplemental imaging is critical for people with category C and D, not just D, but C too. I am living proof. I have C density, and so are thousands of others. So I kindly request your support in advocating for an update of breast screening protocols in Manitoba. Thank you.